Good morning, everyone, and welcome to our Population Data Science webinar series. Today, the presentation will be on linking education and hospital data in England. I'm really pleased to present the speakers for today, Dr. Nicholas Labouie. He is a research fellow at the Center for Longitudinal Studies at UCL, working on a broad range of topics focusing on public health, education, labor, and socioeconomic conditions. His research uses administrative data and longitudinal studies to explore causal associations over the life course. So welcome, Nicholas. Dr. Louise McGrath-Lone is a senior research fellow in the Public Health Data Science at UCL Institute of Health Informatics. Louise's research focuses on exploring health and education outcomes for vulnerable groups, in particular, children in contact with social care services. She has expertise in the use of administrative social care data, including in developing the infrastructure of the ECHILD Database, a linked education, health, social care administrative data set. So welcome, Louise. Really pleased to have you both here. I appreciate your time and sharing with our Population Data Science series, and welcome everyone who was able to attend this morning. So without further ado, I'll pass it over to Nicholas. Thanks very much.
Thank you. Thank you everyone for attending to this seminar. So with Luis, we will talk about a really exciting project called the ECHILD, which is leading by the University College London, but involve a large group of academics from different institutions, including the London School of Economics, the Institute of Fiscal Studies, and collaborators from other universities. It's supported by ECHILD Digital, the Department for Education, the Office for National Statistics, which are the institutions who provide the data, and it's funded by the National Institute for Health Research. Today, we are going to talk about three main topics. First, I will describe what the ECHILD database is. Then I will talk about the result of the linkage evaluation for 4 cohorts of the ECHILD. This is based on research that has been published on the International Journal of Population Data Science. And finally, Luis will discuss how is the ECHILD database currently used in research. So, what is the ECHILD database? The ECHILD database brings together 2 datasets that are already collected separately in schools and hospitals in England. The first dataset is called the National Pupil Database, which has information about absence, exam result, and special education needs support. The other dataset is called Hospital Statistics, that I will be referring as HES, which has information about hospital admissions, including diagnosis, treatments, and operation. To create this new ECHILD database, we linked information from NPD and HES for all children in England who were born on or after the 1st of September of 1995. One of the key strengths of this project is that we create a de-identified large and longitudinal dataset that is covering around 14.7 million of students in England. The ECHILD database is not just one linked dataset, but a group of complex administrative datasets collected by hospitals and schools. In particular, the HES database includes hospital records for all NHS patients in England, include patient demographics and standardized code for diagnosis, symptoms, and procedures. It is collected by NHS Digital regularly from hospital care providers on an ongoing, and this is on an ongoing basis. On the other hand, the National Pupil Database includes pupil demographics and information related to both education and social care, information collected from schools, local authorities, and exam awarding bodies, and it is created by the Department for Education. The period in which each of these database or files is collected varies over time, which is at a level of complexity for researchers. So for example, while the admitted patient care database has been collected continuously since 1997, The accident and emergency, so A&E database, include complete records in 2012. Something similar happened with the MPG data, where the exclusion date database has been collected in 2001. However, student absence has been systematically collected only since 2005. Another important difference between education and health record is that health records are structured according to financial years in England, so it started in April of each year. However, MPG data, the educational record, is collected following academic years, starting in September of each year. The purpose of the data collection is also different. Health data has served as the basis for payment by results, which is a pay for performance system of secondary care reimbursement in the NHS internal market. NPD data, however, is used among many things for funding purposes, measure school performance and research, among other things. So now, how the linkage work between these two databases. So this figure shows an example of how the ECHILD database looks like. On the one hand, has include pseudo HES ID created by NHS Digital and of course patient information. NPD data include anonymized pupil matching reference or APMR ID created by the Department for Education and of course students information. The issue is that this database has not previously been linked for children in England because they do not share a unique identifier. So linkage between these datasets can only be done in a secure environment using linkage methods that use confidential personal identifiers such as full name, postcode, date of birth, and sex. So what I will show you this more detail about this later. So after linkage, a linkage spine is created, including the linkage step, which has to do with the method that we use to link these two databases. And it records at which step the linkage was done. I will explain this in detail in a few moments. So, for example, in this figure, we see the result after linkage. Here we observe a student that was linked to two different hospital records, for example, in which the first record was linked at the step 1.5, and the second record was linked at the step 2.5. What is important is that the result of the linkage procedure produce a complete de-identified database that can be used for research. So let's talk a little bit about the population that is covered. So the ECHILD include all children in England born on or after 1st of September of 1995. But in practice, there are some groups who are not included. So in HES, for example, children who have never had NHS hospital care are excluded. This includes patients in private care only, those home births or recent immigrants. In NPD, children who were never in the state school are also excluded. For example, students in private schools or homeschool children. And also, children who were in contact with social care services only before school starting age. So these are also excluded. So overall, the ECHILD database has several strengths, but also some limitations. So among the strengths is contain information related to health, education, and social care. It is a longitudinal database for the whole population based on cohort of children and young people. It's made up of well-documented existing databases that are created by proper institutions in England. And the idea behind this project is that it will reduce duplication of effort and the access times for researchers and public. Of course, there are limitations with this database, and one of them is that it's based on administrative data that is not collected for research purposes necessarily. Of course, the availability of information varies over time, which make a change when you're interested in analyzing specific research questions. And of course, there are potential for linkage error, and it is a complex, large data. Another important thing that we would like to stress here is that as part of the ECHILD project, we were also interested on interact and learn from young people, parents, and carers. So we facilitated 9 sessions involving around 100 participants. And working with the participant of this session, we learned that there are high level of acceptance of research using administrative data, specifically when this data is de-identified and safeguarded. We observe also there is a good support for linkage across health and education, and there are significant interest in expanding linkage to other administrative databases such as mental health or benefits and so on. However, we also learn that it is important to raise public awareness of administrative data. So I think that for all researchers looking to work with this data, that is something that you have to take into consideration. And there is a need to improve accessibility of administrative data for research. And there is some skepticism about how administrative data can capture individual experience. Again, this is just administrative records over time, so of course it's not everything. So this is, I hope that this gives you a broad idea about what the ECHILD database is, and Luis, we will talk about that later. So now I'm going to briefly discuss the result of the linkage evaluation for 4 cohorts. In particular, I'm going to talk about children who were born in the academic year of 1991, 1996, 97, 99, and 2000, and 2004, and 2005. 3 of these 4 cohorts are part of the ECHILD database. And as I mentioned before, the linkage, it's important to remember that the linkage between the National Pupil Database and health record can only be done in a secure environment and using linkage method that use confidential personal identifiers such as full name, the history of addresses, the date of birth, and sex. So let me explain you a little bit about how the linkage was done and which institutions were involved. So this figure shows the overall data flow process between the Department for Education, NHS Digital, and the Office for National Statistics and University College London. The linkage process for this specific project is divided in 3 stages. Stage 1 involved the transfers of a linkage file from the Department for Education to NHS Digital for linkage to the Personal Demographic Service Database, or as I will call this, is the PDS. This file contains the full name of postcode and postcode histories, another personal identifier. It is a national electronic database held by NHS Digital that contains personal information, and important, it is linked to the NHS number. To link the National Pupil Database and PDS, we rely on a first deterministic linkage algorithm that used 8 steps. That I will describe this a little bit in detail later. So that was the first stage. The second stage, the second stage involved linking the PDS table of identifiers with HES for those children who were linked to National Pupil Database at the previous stage. And this second stage used a 7-step algorithm developed by NHS Digital. So there are 2 algorithms that happen sequentially. After these 2 algorithms were used, the linkage, a linkage spine data was created, which did not contain any confidential data such the name, the date of birth, or and it contains all possible linkage pairs. So this includes linked and unlinked resulting from linkage stages 1 and 2. Finally, the linkage was moved to a secure environment at the Office for National Statistics, where we link a copy of the UCL of HES that was held by UCL with the National Pupil Database. So the key message of this whole figure is that identifiers and attribute data that could be used to identify students was always managed separately to avoid disclosure during the linkage process. So now that you know how we did this, let me give you the main results. So the figure shows linkage rate for each cohort and for the 3 linkage stages that I just described. In the first stage, NPD data was linked to PDS. In the second stage, PDS was linked to HAS. And finally, in the third stage, NPD data was linked with a UCL copy of HAS. So the key message is that the overall linkage rate ranges from 92% for the cohort born in the academic year 1991 to 99% for the cohort born in 2004-2005, showing that linkage rate is high and improves over time. So in the linkage stage 1, we use an A-step deterministic algorithm to link NPD to PDS, and this table shows the step of the algorithm. Results show that between 91 and 96% of records from NPD link to PDS at step 1. So this step is when we use the full name, date of birth, and gender and postcode history that are matching exactly. So in both records are exactly the same. While this number may suggest that subsequent steps are less relevant, we find that 83% of records linked in step 1 are white ethnicity, which contrasts with a 62% of records linked in subsequent steps, so in step from 2 to 8. In other words, steps between 2 and 8 are important to reduce linkage biases associated with ethnic minorities. So that is one of the first main results that we find. The same evidence is observed when we evaluate linkage steps of the algorithm used to link PDS to HES, so in the second stage. Now, let me show you evidence of how improvement in the institution could help to improve linkage. So this figure shows the cumulative percentage of records linked in stage 1 from NPD to PDS by academic year of a spring census. This is data in the National Pupil Database. It shows that while most of records are linked in the first 2 academic years, an important percentage of records are linked in subsequent academic year. So what this is saying is that when linking education with health record, you need to use the full history of pupils in the system, not only one specific instance. Now, to evaluate the linkage quality, we use different methods. So this is the most simple one. We compute linkage rate by different student demographic characteristics. This figure shows matching rate or linkage rate by ethnic groups as recorded in National Pupil Database. It is the percentage of NPD records linked to any HAS record. Linkage rate by ethnicity show that ethnic minorities have lower linkage rate than white students, and that linkage has improved over time for all ethnic groups. We did a similar exercise using the size of income deprivation as recorded in NPD, and we observed similar results in which students from more deprived areas have lower linkage rate than the students from more affluent areas. You could see that the linkage rate gradient of deprivation this size is less steep for the youngest cohorts. We were also interested in looking at geographical variation of this, and so this map shows the opposite. So the unlinked rate from NPD to HAS and we observed that the link rate improved over time across all local authorities. So in particular, we observed that linkage rates in London, east of England, southeast are lower than in the rest of England, but in general, we observe a consistent improvement over time and across local authorities. So I hope that gives you like a general idea of what you could find in more detail in the paper. So just to summarize the main results, so we find that the overall linkage rate from NPG to HES is good, between 92 and 99%, and improves over time. Regarding the linkage algorithm, which are similar for this specific project, which are similar to the one used for the ECHILD, we observed that various linkage steps disproportionately capture non-white groups. We also find that an important proportion of students linked using data not from the first available school census, but also from subsequent censuses, showing the need to match over time, longitudinally. In other words, using all available NPG census years data. It also highlights the importance of using a multi-step approach at both linkage stages. The analysis of linkage biases show that there is still a deficit in linkage success for non-white and disadvantaged groups that could lead to underestimate some health problems in unrepresented groups. We find similar evidence when we use other type of methods. For example, when we compare linked with unlinked population using a standardized difference for a range group of characteristics, and also logistic regression models to assess how student characteristics could be associated with linkage success, and all evidence point in the same direction. So, of course, a solution to this could be to create weights similar to non-response weights in surveys, treating unlinked groups as missing, for example. But of course, this will depend on the specific research question that is analyzed. And we will discuss this later. And if you have questions, please just let us know. Now I will leave Luis that we talk about this in the next part.
Brilliant. Thanks, Nicholas. So this database is really a brand new data resource. So the data, that whole linkage process that Nicholas has just talked us through so thoroughly, it really only happened in the last 12 months. And that data set that was created only became available for research around May this year. So it's really brand new, but it's currently being used in a range of projects that I'm going to describe to you now. Next slide, please. So the ECHILD database was created as part of the ECHILD project, and that had the remit of conducting research that examines the relationships between children and young people's education and health. So under that kind of broad umbrella of the ECHILD project, we currently have 3 ongoing projects that I'm going to talk you through today, and they're in various stages of progress. And they all involve UCL, but there are collaborators in other academic institutions and data providers, and also some schools are involved as well. Next slide, please. So the first project that I'm going to talk about today is the HOPE project, and the aim of this project is to assess the effects of support for special educational needs or disabilities in schools on children's health outcomes. So there's been quite a bit of research that looks at the impact of children receiving SEN support on their educational attainment, but what hasn't really been studied is the broader effects in terms of health and well-being. And partly that's to do with the fact, as Nicholas said, it hasn't been possible before the ECHILD database to actually link the administrative health and education data. So the HOPE project is currently being set up. It's just getting underway at the moment. And the questions that the research team are going to be looking at are, firstly, can we use the health information that's recorded in these hospital data sets to try to define some groups of children who are likely to need SEN support as they move through the school system? And then based on that population of children who are likely to need it, we can look at who actually received it in schools and examine the variation in that across local authorities and different regions of the country. And then finally, the project hopes to use some causal methods to try and assess the impact of the timing and duration of SEN provision on improving health outcomes for these children. Next slide, please. So the second project that falls under the ECHILD umbrella is looking at the relationship between being born preterm and your later educational outcomes in school. So this is a project that Nicholas is working on, and the analysis is complete and hopefully be published very soon. And basically it's looking at the association between being born between 24 and 36 weeks of gestation, and how that impacts on your outcomes once you get into primary school. And this is, again, research that has been done in other countries that have these established health education administrative data sets have shown that there is a relationship between these two factors, but it hasn't been possible to do the same in England until the establishment of the ECHILD database. Next slide, please. So this project, the ECHILD COVID project, is one that has been completed now. So the aim of this project was to look at changes in hospital contacts during the pandemic among vulnerable children and young people in England compared to their peers. So this was a piece of work that was commissioned by the Department of Health and Social Care, and they were interested in understanding how hospitals responded during the pandemic in terms of providing care to vulnerable groups. And so the kinds of outcomes that we were able to look at were the rates of planned and unplanned hospital contacts. So planned contacts being outpatient attendances and planned admissions, and then the unplanned hospital admissions as well. So it wasn't possible to look at A&E attendances using this data set because there's been a change in how A&E data has been collected in the last 12 months, which means that for the COVID period, it isn't possible yet to link it into the ECHILD database. So what we did is we looked at the rates of these different contacts and then calculated the deficits that vulnerable groups experienced. And we also looked at the mode of outpatient attendances, given that there was such a shift from in-person care to kind of remote tele or virtual care during the pandemic. Next slide, please. So obviously the concept of vulnerability is a difficult one to kind of pin down, and we only had about 6 months to do this project, so we needed to focus on some exemplar groups. So we used this framework, which is the Childhood Vulnerability and COVID-19 framework developed by Public Health England, that sets out these three kind of broad groupings of children who may have been affected by COVID-19 based on different vulnerabilities. And what we did is we chose two examples that fit with this framework. So the first example were children who were born preterm or with low birth weight and who had a chronic health condition. And we looked at their outcomes before the age of 5. And so this was an example of a group of children who were likely to be clinically vulnerable during the pandemic and have been affected by delays to getting the treatment and interventions they need due to all the unprecedented changes in hospital care. Then the second example we looked at were an older age group. So we looked at adolescents aged 11 to 16 years who had a social worker or who were receiving SEN support in school. And so these were an example of a group of children who could be considered vulnerable because they're receiving statutory support and are likely to be at increased risk of adverse outcomes during COVID-19 because of all the changes to these statutory support services, so school closures and social work being conducted more remotely, and also to do with the family and social circumstances that have led them to need these support services to begin with. Next slide, please. So what we did is, because the ECHILD database is a longitudinal database, we were able to look back over the 5 years preceding the pandemic, so 2015 to 2019, And we used this to establish a kind of pre-pandemic baseline. So we looked at the rates of these different hospital contacts in the 5 years before the pandemic. And then based on that information, we predicted using a Poisson model what we would have expected the likely rates to have been had the pandemic not happened. And then we looked at the difference between what we kind of expected based on the prediction and what we actually observed based on what was recorded in the data set. And then that difference was one of the main outcomes. So it became the deficit that we were attributing to the pandemic. And we also then looked just at the percentage of outpatient attendances that were in person versus tele or virtual. So all of this research was related to a 9-month period between 23rd of March, which was the beginning of the COVID lockdowns in England, up until the 31st of December, which was the most recent time point that we had data for at the time of the analysis. Next slide, please. So one of the first things we found is that these childhood vulnerabilities are really common. So when we're talking about vulnerable children, we're talking about quite substantial groups of the population. So thinking about the under 5-year-olds, what we found is that 1 in 5 children under the age of 5 had a chronic health condition already diagnosed by that age, or had been born too early or too small. And there was overlap between these vulnerabilities. So 2.5% of children had both a chronic health condition and a kind of adverse birth outcome in that they were born too small or too soon. Next slide, please. And similar picture for the older adolescents. So again, amongst the secondary school pupils included in this analysis, 1 in 5 had one of these social vulnerabilities. So they were either receiving special educational needs support in schools or receiving children's social care services. And again, there's overlap between these groups. So 2.7% of them are getting input from both schools and children's social care services at the time of the pandemic. Next, please. So this graph shows the difference between those expected or predicted rates of hospital contacts that we would have expected to see in 2020 and what we actually saw amongst these two vulnerable groups that we were focusing on. And so what you can see here is that the greatest decrease in rates were in outpatient attendances, which makes sense because that's the most common type of contact with hospitals that children have. And what you can also see is that the children who are part of these vulnerable groups have much greater decreases in rates than their non-vulnerable peers. So the grey bars are children who don't fall into one of these categories of vulnerability, and then the coloured bars are the different groups. And what you can also see is that it's the children who have these multiple kind of overlapping vulnerabilities. So the orange bars for the secondary school pupils and the light green for the under 5-year-olds. So those children, they again are experiencing the greatest decreases in rates. Next, please. So as well as looking at the decrease in rates, what we also looked at was the absolute kind of deficit in terms of the contact with hospitals that children had missed out on in this 9-month period. And what we found is that the children in these two vulnerable groups had very large deficits in hospital contacts in these 9 months. So more than 270,000 fewer outpatient attendances, 40,000 fewer planned admissions, and more than 80,000 fewer unplanned hospital admissions just in this 9-month period. What we could also see is that, as well as being extremely large, they were disproportionately being borne by these vulnerable groups. So although the children in the vulnerable groups for under 5s and for secondary school pupils made up around 1 in 5 of the population, they were bearing a much greater proportion of the deficits. So for example, Among the under 5-year-olds, 60% of the deficit in planned admission was attributable to this, 1 in 5 of the children who actually have a vulnerability. So disproportionately represented in terms of these deficits. Next slide, please. So the last thing that we looked at in this analysis was the mode of outpatient attendance, and we were interested in this because obviously without remote consultations, without tele or virtual appointments, then the capacity to see children face to face would have been greatly diminished. And so if we hadn't had this option of remote consultations, then children would have missed out on even more than the 270,000 attendances they already missed out on. But what we were interested in exploring was whether there was any kind of inequality of access in terms of vulnerable groups being able to attend face-to-face versus virtual or remote appointments. And what we found is that during the pandemic, vulnerable children were much less likely to receive face-to-face outpatient care than their peers. And this was a combination of things. So they were less likely to be offered face-to-face care in the first place. And when they were offered face-to-face care, they were less likely to attend it, and which meant that they were being offered and attending more virtual appointments than face-to-face. And obviously it's better to see somebody remotely than to not see somebody at all, but there are some things that need to be considered about this mode of care, given that it's so brand new and really has been untested for children in terms of how safe and effective it is. And a couple of things that have come out is that there can be difficulties in terms of the ease of access. So not all families will have the broadband speed to kind of effectively have these video consultations. There can be misunderstandings and difficulties building rapport between professionals and the patients, and particularly for children and for those who are involved in social care services already, there are some safeguarding concerns in terms of health professionals don't always know who else is in the room during these consultations, and it can be more difficult to pick up on those non-verbal cues that might be really important. So next slide, please. So there are some limitations to this study. It uses a very simple classification of vulnerability. So we selected just 2 groups that we could kind of readily identify from administrative data sets. But it obviously doesn't capture all of the nuance within those groups. So when we talk about children who have a chronic health condition or are receiving special educational needs, for example, that's going to be a very heterogeneous population. And putting them all together is a very simple way of looking at vulnerability. The other big limitation is that in no way does this analysis capture the full extent of the deficits in hospital care that children experienced. It's looking at 2 age groups, 2 example vulnerable groups over the first 9 months only. So you can just imagine the actual true scale of the deficits in hospital care that children have experienced is going to be far, far greater than the figures we're presenting here. Next, please. So notwithstanding the limitations, there are some kind of key messages that came out of this analysis for us. And the first one is that it looks like some sort of targeted catch-up funding and resources for child health specifically is needed. So a bit like the NHS health and social care levy that's being ring-fenced for care, perhaps there needs to be some similar kind of targeted funding for child health particularly. And vulnerable groups who've been disproportionately affected also need to feature in the kind of catch-up plans and funding and resources. It also seems that certain groups might need to be prioritised for face-to-face outpatient care. So it's not clear how effective remote care is for those children. And so as we move into the recovery phase where face-to-face is more possible, then maybe there needs to be some kind of prioritisation of these vulnerable groups. And the last kind of implication is that what we've done is start to kind of quantify what the deficits and delays have been in terms of access to hospital care. But what's really difficult to do is to then think about or predict what the consequences of that might be. So if you think about adults, we know that there's lots of research that shows us that delays to care have adverse consequences. So if you think about the research about cancer waiting times, so we know that the longer people are delayed in starting their cancer treatment, the worse their outcomes are. But there's no kind of similar body of evidence that deals with the huge range of childhood conditions. And so it's very difficult to kind of think about what are the impacts of these delays likely to be. And so what we really need is some more research that looks at how delays to treatment for childhood conditions impact not just their health, but also their education outcomes in later life. So this project is completed and there's a report available now on the UCL website. So please feel free to read in more detail. I think that's it.
Great. Thank you, Nicholas and Louise, for an excellent presentation. A lot of detail, which I know people will probably be very excited to learn about and probably compare to future work. I know, as you mentioned, this kind of work has been done in other countries, but the magnitude of your ECHILD database is excellent. So I know that'll be great work for more things to come in the future. The floor is now open to questions. I do have a few questions just to start us off. So the first one is, does the ECHILD database currently contain looked after children and in need data from NPD?
Yes, it does. So the ECHILD database includes both of the modules that relate to social care that are collected as part of the NPD. So we have the children looked after module going back to all the way to 95, and then the child in need module, which came in the 2000s. And just to say that because of the way the looked after data was collected between 98 and 2003, it was only collected for a 1/3 sample. So although we have all of the data in the ECHILD database, it wasn't collected, and so therefore isn't available for 2/3 of that population at that point in time.
Great, thank you. Next question, could you expand on linkage bias for ethnic minorities and children from deprived areas? What was the reason for it?
So that's an excellent question that we will not were not able to answer in that specific research and in that specific paper. We were more interested to more kind of describe what could be the group that are kind of being affected by these linkage biases. But we do have some hypotheses. One could be that ethnic minorities, for example, have different, more complex surnames or different structure of name, or just simply underreport, or the way that they report the name is different, is harder for white ethnic group, for example. And that could be an issue when using linkage algorithms that are based on the spell name, the full name, for example. That could be one issue. But you know, we don't exactly know about this. It's more like a descriptive. These are mainly hypotheses. It would be nice to look in more detail, but for that we will need to have access to some specific data. Another hypothesis is that it has to do with the collection of addresses. So in England, in general, with the postcode system, addresses are really well collected, but it might be that the addresses are disproportionately bad recorded for some specific group, and that then could affect the way that we are using postcodes and addresses to link information between them. And I think those are could be two main hypotheses that we are thinking right now.
Okay, thank you. Next question. Are there plans in the future to link the ECHILD database to Millennium cohort study data?
There are no plans to do that. So the ECHILD database, as it currently stands with these modules that are on the screen here, that's the kind of original ECHILD database as it is. And we are currently working on establishing the permissions to expand the ECHILD database. So that would include going back further in terms of who's included, so back to the 1980s in terms of births, and also expanding the range of health data sets that are included. So linking in mental health data, for example, that is captured by the HES data sets. So those are kind of the next steps that are being worked on in terms of expanding the database. And cohort studies haven't really been something that has been considered because it's focusing on admin data, but it's certainly something that could be possible. So I know that Millennium Cohort Study has been linked to the social care data set, so technically is possible. It would just be about establishing the permissions to get that done, which is no mean feat. I think kind of the ECHILD database began as an idea probably 8 years ago, and it's taken quite a bit of time to build up the permissions to get it to this stage. But I can see the value, because obviously what administrative data sets lack in detail, the cohort studies obviously would be a huge kind of supplementation for that.
Great, thank you.
Just to add to this, the Millennium Cohort has been linked to some modules of NTP data, and it can be accessed through the proper mechanism, I think. And recently, some effort has been done to link with HES data. So it might be that there is information for some modules of NTP that is already linked and for people to access through CLI. But just want to mention that in case it's useful.
Great, thank you. Next question. What was the rationale behind performing a deterministic linkage rather than a probabilistic one?
Well, maybe I'm not the best person to answer that question because we don't have Katie who were any rules who were involved from the beginning. And my thought on that is that there was already some linkage done within linkage algorithm that were working at the NHS Digital already. In fact, one reason could be that it's just that, but to be honest, I'm not completely aware about the history behind why this particular method was used for this. I think it also has to do with complexity of other methods and how you could be transparent on using those that such probability linkage and so on. But yeah, maybe I could answer that later to that person.
Okay. All right, thank you. Next question. Have you published a paper about the linkage algorithm? I'd be interested to read it.
I think no. The only information that we have provided is in the appendices of the paper of our paper, which is in the Journal of International Journal of Population Data Science, which is this paper. So we try to describe in detail the decisions that were made in the appendices of this paper. So yeah, and there is more research. So if you are interested, maybe you could look at Katie Haran work in this area. I think that would be a good start.
Okay, thank you. And I'm not sure if you've maybe already partially addressed this question. Are you interested in linking data from primary care to ECHILD data?
Yes, so primary care is obviously the kind of missing element of health data that isn't included. This is only hospital data at the moment. And I suppose, so primary care, it would be a natural kind of extension of the ECHILD database. And I suppose the rationale for going for mental health data next, as opposed to the primary care, really came out of the public engagement work we did. So when we were speaking to the young people, all the questions they wanted us to try and answer to do with that relationship between health and education focused on mental health primarily. And that is something that isn't really being picked up in hospital. So the kind of natural extension would be the mental health specific data sets and then primary care. So it is on our radar, but it's just these things take a very long time.
Yeah, we can certainly appreciate that. I know just obviously getting permission to use data from multiple different sources is always a challenge. What was the timing behind just all of that for you? Did you several years before you had all the data?
So I think the first I heard of the ECHILD database was in 2014. So that's 7 years ago. And yeah, it's really been a kind of process of building relationships and kind of building an understanding amongst the actual data owners that this is going to be an amazing resource for research and for them as well. Yeah. And one of the things that in a way sort of helped the case was COVID, because it was so obvious that by having this link between health and education, you were going to be able to look at the impact. So as much as COVID kind of slowed down the process of linking the data, it also kind of added a kind of impetus that this was, something that needed to be pursued. Yeah, and as I said, the actual kind of full ECHILD database only landed with us in May this year, I think. So it's brand new in terms of, the potential for research that's there is absolutely huge and untapped, really.
Yeah, lots of huge possibilities there, and I know you're right. We certainly on this side of our side of the pond, just in terms of COVID and how much interest there is in mental health related to that, right? So that seems to be a natural connection for sure. Yeah. So I don't see any further questions. I don't know if other people have anything else they'd like to add, but I know we've really enjoyed all the information you provided, and kudos to you and your team for getting the ECHILD database up and running and all the work that you'll do now and in the future. It's very exciting, I'm sure. Anything else you'd like to add just in terms of next steps and your dreams for the future?
Well, yes, the first thing just to say is that it's an absolutely huge team effort, including all these people listed here. And also the bit that might not have come across in this is that this is a resource that was created as part of the ECHILD project, but the vision is that it would be made available to other researchers for their own research projects. And so as well as kind of pursuing the expansion of ECHILD database, the PI of the study, Ruth Gilbert, is also very much working on making this available to other researchers for their own purposes. So if anyone thinks that it might be useful for their research, then I would encourage you to watch this space, keep in touch.
Great. Thanks again, Nicholas and Louise, for being online this morning and this afternoon in your case, and for presenting. Really appreciate it.
Thank you so much.
Okay.
Thank you.
Thanks, everyone. Bye for now.
Bye.